on the areas that you need to focus on prior to your exam. So keep in mind the way this is broken down so that you can adjust and use your time wisely as you prepare to take the NCLEX exam. Exciting news, isn't it? All right. So let's move on to psychosocial integrity. Now, this particular area deals with these topics. When you think of psychosocial, whether it's things that we do as nurses, but not necessarily direct client care or clinical per se, but it could be things that you need to know as a nurse. Like, how do you deal with somebody who's going through grief and loss? What is an expected outcome when it comes to grief and loss? Okay, if I ask every single person here, how do you expect somebody to deal with grief? I would get 100 different answers, right? Because it's going to be based on your experience, or could be your culture, your knowledge. It could be based on so many things that influence the way you see it should be. So that's why what we're looking at when answering these type of questions in NCLEX is, what is the source of truth? What is it that we're going to use as our standard guide to determine this is the correct answer to this question? Not based on my own thinking or what we do in our country or what we do in our own hospital. We have to have a standard of what we refer to as the source of truth. Now, I want to share with you, this is a little extra tidbit here. There's 4 reasons an answer is correct on the NCLEX exam. You ready? 1, the answer is correct because it's scientifically proven. Most of our medications are given because science supports it, right? We know this clinically works. Second reason is because it's based on evidence, evidence-based practice. Big word, isn't it? That we see and hear a lot in nursing. Evidence-based. Again, there's treatment protocols. There's standing orders, things that we do because we know they work, because evidence supports it. Why do we give ACE inhibitors to heart failure patients? Because we know evidence supports that it works in increasing cardiac output, right? Simple. Another reason could be it's evidence-based. Evidence-based means that not evidence-based, it's by best practice. I'm sorry, that's the third one. Best practice. Best practice tells us that this is the right thing to do, okay? So, like, why do we wash our hands? That's best practice, right? And the fourth one is based on theory. This is where we get into the psychosocial part of this. When we think of theory, what is the theory? Getting back to my original question about grief and loss. What constitutes grief and loss, and what would be the standard? Well, we'll refer to, let's say, Kubler-Ross. Remember, Kubler-Ross came up with the stages of grief? That is the standard that we're going to use to determine if this patient or client is grieving in an expected manner. Are they in the anger stage? Are they in the denial stage? Are they in the acceptance stage? Depending on what the scenario is, that's going to help you determine this is correct. They're not meeting the expectations, so therefore I know we have to do something different. So theories, like another theory would be Erik Erikson's stages of psychosocial development. How do we know how a 14-year-old is going to react to depression? Well, because we know that that particular stage is identity versus growth confusion. We recognize that friends are really important at that stage, as opposed to someone who's 8-year-old who is more incompetent. So these are the sources of truth that we look at. And when we're looking at psychosocial integrity type questions, some of the answers you're going to see is not going to be based on science, but it could be based on some kind of theory. All right. Well, that's my introduction to psychosocial. Hopefully you had a chance to look at the list and go from there. Is this a lot of echo? I'm so sorry about the echo. We have somebody else in the other area that's teaching as well. So I apologize for that. All right. As you know by now, because we do this all the time, we provide you strategies. What are some of the strategies you would use? And I'm not going to spend any time here because you should know this by now. All of this is in Learn Upon. So you've all learned about testing strategies, hopefully. If not, make sure that you go back to your Learn Upon, look at your recorded webinars on coaching clinics, such as 6 Steps to Question Success, Therapeutic Communication, Decision Tree, all that is in there. Okay, so here's our very first question. You ready? Make sure for those of you who are new, you can use the chat to go ahead and type in your answer. The question is as follows. The nurse is setting up supplies to complete a dressing change at 2000 hours on the client's stump following a right BKA, below the knee amputation. The client looks away angrily and says, I don't want to look at that thing. I can't. You come back later? Which is the nurse's best action? All right, I'm going to set my timer for 1 minute and 30 seconds, and I'm going to let you do that. And I'm going to go ahead and take my camera off and put myself on silence, allow you to put in your answers in the chat. Okay, we're back. I'm sorry, I mistimed myself here. I put 1 hour and 30 instead of 1 minute. Okay, so let's see if we can get back to this question. It says the nurse is setting up supplies to complete a dressing change at 2000 hours on the client's stump. Following the right BKA, the client looks away angrily, says, I don't want to look at that thing. Can you come back later? Which is the best action? All right, so if we're using our 6 step strategies, the first thing we're trying to identify is what is the instruction? What is it asking us to do? It says, what's the best action by the nurse? Okay, there could be more than one action, but it's looking for the best action. So we're looking for a therapeutic response to this question. So when we look at that, we think about the topic. What is the topic? In this case, the topic is the client doesn't want to look at that thing referring to obviously the BKA, which is our topic and our keyword. So the question is, what does that mean? What is it we're trying to deal with? We're trying to determine what is going on with the patient's evaluation of what's going on with his leg. So looking at therapeutic communication, let's go through each answer and say, which is the best choice? Number one says, put the supplies away and reattempt the dressing change in 1 hour. Do you think that an hour later the patient's going to feel any differently about his missing leg? Probably not, because we haven't addressed it. So it doesn't seem like number one would even fit the scenario, what we're trying to accomplish as far as our instructions go. So we can eliminate number one. Number two says, tell client, don't worry. This will not take long to complete. I can medicate you for pain prior. What do we know about don't worry answers? We know that's considered non-therapeutic. It's false reassurance. It doesn't address the patient's issues. So you can eliminate any answer that says, don't worry. Bye-bye. Number three, ask the client, why don't you want your dressing changed now? What's another thing we learn about therapeutic communication is you don't ask why. Why don't we ask why? Because why puts the patient on the defensive. It makes the client or the patient feel like they don't have a right to feel what they're feeling, or they have to explain themselves, puts them on the defensive. So it's not an accurate way to it's hard to resist though, isn't it? Don't you often want to say, well, why don't you want to take your meds? Or why don't you want to do this? Or why don't you do that? It's almost natural. So it's really hard to get around the why. Another way to address why type questions when you're trying to figure out is use the nursing process. Think about assessment. You're trying to assess what the patient's thinking. So instead of saying, why don't you want your dressing change? You can even ask it as an education question by saying, often clients who have experienced what you've experienced are not, are feeling angry. You may restate or ask the question a different way without saying why. So number four is not therapeutic, which leaves us the only answer left. You don't want to look at your leg? Could you tell me more? Allow time to response. So this is therapeutic in that it's assessing. Number two, it's an open-ended question. It allows the client to be able to express their feelings and thoughts and allows the nurse to gather more information. So the answer to this question is number four, and we use our therapeutic communication skills to come up with the right answer. Easy peasy, right? Any questions on that one? All right, let's try another question. Number two says, the home health nurse suspects elder mistreatment of a 93-year-old client by the live-in caregiver. Which findings support the nurse's conclusion? Select all that applies. All righty then. All right, I am back. So, the home health nurse suspects elder mistreatment of a 93-year-old client by the live-in caregiver. Which findings support the nurse's conclusion? Select all the apply. We're still using our 6-step strategies here. We're looking at understanding the topic. What looks like abuse or mistreatment? All right, that's our topic. Now, what is an expected outcome when it comes to that? And the fact that the key word here is that she's 93 years old. So we need to differentiate with what do we see? Is this an expected outcome for somebody who's 93? Or is this an expected outcome for somebody who's being mistreated? So that's kind of how you can differentiate by looking at the answers. So number one, client has urine burns. Now, is there any way you're going to get urine burns other than someone who is not changing a diaper, for example, or adult pamper? No, that's not something that would be an expected outcome, even from an elderly client. An elderly client may be incontinent and may need support and care with hygiene. So someone who's caring for this 93-year-old who's ignoring her or neglecting can cause urine burns. So that would be a sign of mistreatment or the fact of neglect here if the patient is not getting their soiled pamper or underwear clean. So that would be definitely a yes. Number two, client has an ulnar deviation of the left hand and fingers. Now notice it didn't say it's broken, right? Ulnar deviation of the right fingers is a sign of sometimes could be rheumatoid arthritis, right? Sometimes arthritic, osteoarthritis, those kind of disorders can cause a deviation in the hands and fingers. So that is not necessarily direct example of mistreatment or neglect or abuse. Okay, so we're going to say no to number two. Number three, client states there have been some unexplained financial expenditures. Okay. When we think of suspected elder abuse or mistreatment or neglect or abuse, that could include financial. An elderly client that relies on a living person to manage their care and their finances that are misusing or misappropriating their finances would consider it an abuse. So yes, number three is a correct answer. Okay. Number four, a client is more talkative than during the previous home visit. Now, we think about expected outcomes for people who are being abused are usually the opposite. They get withdrawn, they get quiet, they get fearful of answering questions incorrectly, especially in front of the abuser. So, someone who's talkative or expressive or social, it's not a sign of abuse. You would expect to see the opposite. So, number four is a no. Number five, smell of alcohol noted on the live-in caregiver's breath. Well, we know substance abuse can be a characteristic of an abuser, so that could be a sign of something going on. Okay? They were not hard, right? These are plain kind of even common sense when you think about it, when you look at it. I think the one that threw people off was number two. Think about if you can explain this by other means other than abuse, let's say normal changes in certain ones as we get older, we get brittle bones, we have looser skin, less connectivity, all of those things can be explained by normal physiological changes, then it would not be considered abuse because we would expect to see that. Number three, it says client says that he's been unexplained financial expenditure, meaning that the person taking care of the elderly person is misusing their finances, Maybe they're stealing money from them, writing checks, taking money out of the bank account, having the client sign over something they don't know that they're signing that has to do with financial gain for the abuser or for the caregiver. That is considered an abuse. Because the client doesn't know that they're unaware, they're not doing it. That's why the key word here is unexplained. Did that help you? Okay. All right, good. Let's go to another question. Let's look at number 3. All right. An elderly female client who is Japanese and does not speak or understand English is hospitalized. Which intervention should the nurse utilize to promote effective communication? Another select all that apply. All right. An elderly female client who is Japanese and does not speak or understand English is hospitalized. Which intervention should the nurse utilize to promote effective communication? Select all the apply. Now, when we think about select all the apply questions, besides using our 6-step strategies, remember we're using understanding the instruction, topic, keywords. We're going to define our topic and what is expected outcome. These are all part of our 6-step strategies. But I just want to give you another little tip. When answering select all the apply, there are 3 things you want to look at when you look at the answer. You got to ask yourself for each answer, is this a yes? Is this a no? And why? Why is important for you to be able to justify your answer? Why do you think it's a yes? Why do you think it's a no? Because a lot of times when we look at select all the apply, overall, at least our first impression is, hey, that sounds good. Sounds like a good answer. I think that's right. But when you take a deeper dive and you think about, well, let me think about how it relates to my topic, then you go, it doesn't apply here. It may not be consistent with this particular scenario. So you always want to ask yourself why, okay? So let's take a look at number 1. It says place a picture communication board at the bedside for the client and family to use. Pictures is a great way of communication. It's really universal. So if you have a picture of somebody, with a picture of a bathroom and the patient can point to it, then you know that they're asking to go to the bathroom. Or if it's a picture of a fork and spoon or plate, then they point to it, they're hungry because that's universal. That can be effective in communication's basic needs. Basic needs. So number 1 would be a correct way. It's an effective way to communicate. Number two would be work with the family to write down a list of common client requests in English and Japanese. In other words, again, understanding the words for pain or bathroom or hungry or thirsty. Simple words like that to communicate the basic needs the patient has can be very helpful. That if you recognize this is the name for water in Japanese, they point to it, you can see what they're saying. You can recognize this. That could be helpful for basic needs. Okay, so if you selected two, you were correct. Number three, ask that a family member always be present so that the client will have a translator. Keep in mind that in NCLEX, there are really in nursing, there's no such things as absolutes. No such thing as always and never. Okay. So if that has an always or never in there, you can eliminate that because it's not realistic to ask for family members to always be present. Okay. It's not really their responsibility at this point to take care of their needs in the hospital. All right. They can be helpful, and many family members, especially in certain cultures, insist on staying with the patient. Maybe that is part of their culture and we will respect that, but it's not necessarily the best way to translate, especially for medical things. We're going to get to that in just a moment. I'm going to explain a few more things regarding that. So the answer to three would be a no. Explain that several nurses who are Eastern Asian can be available to help the client. What's wrong with that answer? Well, first of all, we know that in certain cultures or there are different dialects. So just because someone's from the same area doesn't mean that they can translate effectively. Do they even know the right dialect and speak that language? Number two, we really need to have official translator when we're talking to clients about things other than basic needs. So again, we're not going to be using nurses that just because they're part of the same area, they necessarily are going to be effective in communicating with the patient. And then inform the family that all nursing staff are required to have cultural sensitivity training. That may be well and good, but has nothing to do with communication. Effective communication is not going to help in this particular situation. So the answer is no. But I wanted to go back to something very important. As we can use communication boards or simple translation of words can communicate basic needs, cares of daily living, it's not related to their medical care. If it has anything to do with their Medicare, like signing a consent, giving information about medications, a plan of care, or discharge instruction, you really need to be used an official translator. Every hospital has their official translators, whether they have them within the facility or they have a connection through a phone or using a laptop. Whatever mechanism or process that they have, you are required legally to use legal translators or official translator, because when communicating medical needs, the patient has a right. These are the basic rights of every patient to understand their care. If we are not giving them the information accurately and to the point where they can sign informed consent, we could be legally responsible for anything that they may have decided that they weren't aware of. So always, if you get a question about legal nursing, remember you want to use official translators. You can't just use the housekeeper because they speak Spanish and the person's Spanish. You can't do that. Or some other nurse or some other person, because again, we're translating medical terminologies. Patients who speak common language may not be able to translate those medical terms and explain it in a way that is appropriate. Does that make sense? Well, number two says if the family can write down a list of words that we can recognize in Japanese, is what I'm trying to say. For example, I'm Spanish speaking. Okay. If my mother was in the hospital and I could write down certain words in Spanish and right next to it, write the English word for it so that the nurse, when she hears my mother say agua, she'll know she means water. So I'm talking about, certain simple words. Again, meeting those basic needs, it's okay. It's a good, effective way to communicate, not the only way. It's not everything you're going to do, but it can help the nurse or caregiver to understand certain words mean certain things. Most nurses, know dolor, that's pain, right? In Spanish. I can't speak Japanese, so I don't know what the Japanese word is, but you get my point. Sometimes just having those simple list of words can help in the immediate, in the moment, because you don't have time to call an official translator to find out that the patient has to go to the bathroom, okay? Because they got to go. Instead of involving the family. No, you don't necessarily want to involve the family, but you could involve the family if they're right there to get those simple words, like I said. And again, that's the only reason we would even do that is for those simple, basic needs. What I mean by basic needs, going to the bathroom, water, thirst, hungry, pain, meeting those immediate things that has to happen. Having those words can help the caregiver go, okay, I know that they need something for pain. I can't wait to get somebody on the phone that may take me 20 minutes to get an official translator to tell me something that I can get easily by just one word phrases or using the picture board. Did that help? Okay, good deal. All right. Now, let's move on to the next question. Number 4, it says, the recently discharged veteran who served in active combat reports symptoms of recurring intrusive thoughts, insomnia, and hypervigilance. Which question would be most helpful in establishing a diagnosis? All right. All right. The recently discharged veteran who served in active combat reports symptoms of recurring intrusive thoughts, insomnia, and hypervigilance. Which question would be most helpful in establishing a diagnosis? Now, this is why it's important to use the 6 steps, because you should already know what the answer is before you looked at the answers. Think about the 6 steps. Step 1, the question is asking what is most helpful in establishing a diagnosis. That's the instruction. That's what we're trying to get to. The topic here is the assessment or the symptoms that are being described. The symptoms being described are recurrent intrusive thoughts, insomnia, and hypervigilance. That's our topic. Okay. Now, the key word is this is a veteran that has been in combat. Now, step 4, remember we have to define our topic, but I can't define my topic until I first interpret what these words mean. What do they mean when you put them together? This is what critical thinking is putting the pieces of a puzzle together to form a picture. Okay? So before I can define this topic, I need to know what it is. So what is my topic? Well, what topic or what diagnosis describes intrusive thoughts, patients with insomnia, and hypervigilance? Okay, so I have Kosi and Ruth Einstein and Tabitha and a whole bunch of more people have given me their response. They're telling me that this is describing PTSD, post-traumatic stress disorder. And it sounds correct, right? All of those ingredients, those puzzle pieces, all seem to fit this particular diagnosis. So with that diagnosis of post-traumatic stress disorder, what would I expect to see? What would be an expected outcome? Then what's my goal? My goal is to establish a diagnosis or look for an answer choice that fits my description. If I'm saying that this is post-traumatic stress disorder, I know what's an expected outcome with those kind of clients. That's what I'm looking for. That's my goal, to identify that. So let's take a look at each one of these. Now, just like we did with select all, they apply, I said you look at your answers yes, no, and why. With standalone questions, you're going to say yes, no, or maybe. You're going to ask yourself, do not make the mistake of reading all of the questions at once. You need to go by one at a time so you're not distracted. Number 1, do you find yourself falling asleep while working? Does that fit our definition of post-traumatic stress disorder? Or can that be explained by a different disorder? What other disorder might be more aligned with somebody that falls asleep while they're working? Anybody? What does that tell you? Fred gets the prize. He was the first one. Narcolepsy, right? That sounds more consistent with somebody with narcolepsy, which is a disorder that produces excessive sleepiness. Okay? Doesn't fit our PTSD, does it? So we can eliminate number 1. Number 2, are you also having nightmares when you do sleep? Is that one of the characteristics of PTSD? Having nightmares while they're asleep? Yes, no, maybe. What do you think? All right. I am getting a lot of yeses. So I agree. It is. In fact, it's one of the classic signs of PTSD is having nightmares. So that fits my disorder. That fits my definition of PTSD along with all the other things we saw in the stem of the question. So I'm liking number 2. So far, it's a yes. Let's take a look at the other answers first. Number 3, your hair seems thin. Are you also pulling at your hair? Now, that can be a characteristic of PTSD, but can it be related to any other disorder that's more specific for that? Anybody? What do you think? Doesn't come to mind? Okay, this is a hard one because I can't even say it, much less spell it. I'm going to read it here of my notes. Trichotillomania, trichotillomania. Did I say that right? It's a disorder that we see with certain psychiatric disorders where a recurrent of pulling out the hair. Um, Now, that could be a high anxiety disorder, which can be related to PTSD, but it's not specific to PTSD. Thank you for spelling that out, Joseph. You are brave. But yes, that is what that disorder is called, but it can be related to anxiety disorders and others. So, not really necessarily PTSD. But number two seems like a better answer than number three, right? Number 4, have you been diagnosed with obsessive compulsive disorder? Now let's think about what compulsive obsessive compulsive disorder is characterized. Is it characterized by insomnia? Is it characterized by hypervigilance? Maybe hypervigilance or intrusive thoughts, nightmares? What are some characteristics of OCD? Cluster perfectionist, says Mercy. That's a good way of describing it. You're right. Characterized by this involuntary, recurring thoughts and um, not thoughts, but organization or method of doing something that has to be repeated. And it's something that they can't help. It's recurring, like washing their hands 5 times or making sure the lock has to be done a certain way or certain order. It's a repetitive behavior. That's a very good. It's compulsive. You're right. It can be a perfectionist, but it can be just someone has a compulsive way of completing a task in a certain way, and they have to do it that way, or their anxieties go up. That doesn't sound like characteristic of our PTSD person, right? So we know that the best answer we came up with was number 2. I know that was a long way around to get to the answer. You probably already knew the answer, but I wanted you to think about the other things and how you think through the questions. If you take your time and you're not rushed to allow yourself to think about each thing and what is the expected outcome, what are some definitions, what are the characteristics, chances are you're going to get it right. Okay? Now, focus on the recent discharged veteran and common disorders associated with trauma, which is what gave us the answer. Now, question 5, it says, the nurse is counseling a mother who has had prolonged grief after the death of her child. Which statement would assist the nurse in assessing whether the mother is experiencing guilt? Interesting. Somebody says active combat. That means they've been in war. They've been in a war. They've been part of active war where they're engaged in those kinds of activities. Okay, let's take a look at this one, okay? So the nurse is counseling the mother who has a prolonged grief after the death of her child. Which statement would assist the nurse in assessing whether the mother's experiencing guilt? Now, this should not have been a difficult question for you if you're using your strategies, okay? So the question is asking, how do we assess if the mother's feeling guilty or not? So that's the instruction, okay? What we know about the client is that the mother lost her child and has had prolonged grief. So we're dealing with grief as our topic. But the question is looking for an assessment. So we're looking for an assessment answer. So it's simple. Let's get rid of anything that's an intervention and keep whatever's an assessment. So let's take a look at number one. What, if any, memories or thoughts are troubling you? So when we ask a question, an open-ended question like this, we're assessing, right? We're trying to get feedback or get insight as to what the patient is thinking. So this is an assessment answer, therefore I'm going to keep it. Number two, tell me about your favorite memories with your child. Okay. This is also an open-ended statement and it supports the mother's expression of positive interventions, but it does not address the negative feelings. Therefore, it's more of an intervention by getting the patient to say this. So we're not looking for intervention, we're looking for an assessment. So again, this one, even if we didn't recognize it as an intervention, it doesn't help us address and trying to identify if the patient's feeling guilty about the loss of their child, right? Number three, writing your feelings in a journal helps overcome a guilt. Well, number one, the nurse is assuming the patient is feeling guilty. We haven't determined that. That's what we're trying to figure out. Is the mother here, the statement assessing whether the mother's feeling or experiencing guilt? We don't know that, so we can't assume that. Number two, this is an intervention answer. Asking the patient to journal is an intervention. Remember, we're looking for an assessment, so we can get rid of number three for that reason. Can I schedule you an appointment with a grief counselor? Again, it's an intervention answer. All right. And it doesn't get to the point we're passing the buck here. So the correct answer to this question is really the only assessment answer we have, which is number one. Okay. That wasn't too bad. All right. So are we ready for our case study? Yes, we are. Okay. So we're going to go through our case study, and just as a reminder, as we always do using the clinical judgment model, you're going to be using our 6 steps, but we also, when looking at assessments, important to identify the cues early on. As we read the scenarios, think about these unexpected outcomes. What do they mean? Let's interpret them and then put them together to come up with a hypothesis. What is this trying to tell me? And based on that hypothesis, what would I expect to do? What would I look for? What would be an assessment, an action, intervention, and how do I evaluate that? Okay, so let's take a look at our little scenario. Okay, we're talking about JR, and we're going to say this is IR. I'm sorry. Is this a female or male? I forgot. Okay, let's just say that IR is a man. We're going to call him Ira. All right. So Ira, age 20, is a psychiatric patient with bipolar disorder. Today, in an outburst, he put his fist through a wall and then turned his rage towards his father. At the request of his father, he is brought by the police to the emergency department. This is third visit to the ED for psychiatric treatment this year. Upon arrival, Ira has a disheveled appearance. Parents report they suspect he stopped taking his medications for bipolar disorder. Ira is fidgeting and pacing during his triage assessment. He is easily agitated by the triage nurse and displays clenched fist. All right. So we've got some things going on here with Ira. All right. So what are some of those things that kind of stand out to you? What are the cues? And then when we put it together, what is our hypothesis? In other words, what's going on with Ira? Okay. So just to keep in mind, for those of you who are new to the program, on the NCLEX exam, you're always going to have access to the scenario as you progress to the case study. Even if you're on question number 5 or even question 6, you could always go back to the original scenario, get the information along with all the appropriate tabs that you're going to be clicking to get further information. Okay, so the first question is asking us to highlight which findings indicate classic signs of potential to become violent. So when looking at highlighting answers in your scenario, go line by line and think about what is the outcome. What is it, the expected outcome you're looking for? So we're looking for those signs and symptoms that somebody will become potentially violent. So let's take a look at this scenario. Ira has a disheveled appearance. Would you consider disheveled appearance something you would highlight? Yes or no? And I'm getting some of your answers here. Let's just go by one line to one line. So I'm getting a lot of yeses. So, all right, let's select that one if that's what you think is correct. Now, if parents report suspect he stopped taking his medication for bipolar, Ira is fidgeting and pacing. Yeah, he doesn't seem calm, does he? So yes, that one makes sense. And that he's also pacing. During his triage assessment, he's easily agitated. I think that one goes without saying. By the triage and displays clenched fist. Okay, I think those are the obvious ones, that this patient has that explosive disorder. Okay. Not the kind of patient you want to hang out with, right? Okay. Now, let's go to the next slide. Now, this gives us some information because it looks like he's been diagnosed on 3/21. Ira was in the ED with that disruptive violent behavior. We know he has bipolar, discharged with a psychiatric referral and prescription. On July 9th of 2022, he came in with a drug overdose. Alert dangerous behavior. Okay, so those are some of the things that we got in the notes from previous past medical history. Now, next slide is this. We have an update. Remember, when you're clicking the case study, it could be nurses' notes, whatever the tab is titled, you always want to click on it with each question because you never know when there's going to be updated information. NCLEX is really good about telling you on the right side, hey, there's new information you might want to look at, the way they're explaining. So now we have, this is the original, the triage nurse noticed the cues right away. He contacts the security since the patient is brought to the ED by the police. He reviews Ira's previous hospital records, as we just saw, and after his triage interview with the patient, he contacts the psychiatric nurse to provide her a report, including history of the patient. He is also flags Ira record to alert, making sure everybody knows about Ira's behavior to other staff who may encounter him during this and future visits. The security officer performs a weapons check as routine practice when patients are presented by the police or if they have a record of past violence. He does not leave Ira alone with the nursing staff. He escorts Ira to the psychiatric consulting office rather than releasing Ira to move through the hospital. Sounds like a smart thing to do, right? Now, the question here is, what workplace safety practice controls appear to be in place in this scenario? Select all that apply. Let me give you a shorter time for this one. All right. Did everybody get a chance on that one? I didn't give you the full minute and a half, but I think a lot of this is common sense. This one's not hard to do. Now, just as a reminder, again, with select all the apply questions, especially in case studies, remember you can get that partial credit, that plus minus scoring. Remember, the NGN orientation explains to you how questions are scored in the NCLEX exam. One of them is the plus minus scoring, which is with SATA questions. So let's say whatever number of answers are correct and there's number of questions that are wrong, you get a point for every question you select that's correct. Okay. If you miss a correct answer, you don't select it, you just don't get a point for it. However, if you select a wrong answer, you get a point taken away. So think about each answer. Remember, it's a yes, no, and why. So number one, weapons check. Did they do a weapons check? Is that one of the safety practices that they did? And it sounds like he did. Support weapons check, which makes sense. That sounds like it's right on. Number two, triage performed by the psych nurse. At this point, the psych nurse has not done the evaluation. The psych nurse, um, they contacted the psych nurse to provide her a report, and the security officer is escorting the client to the office, but it was not triage, was not performed by the psych nurse. It was performed by the ED nurse. Sometimes it's a matter of semantic, you know, tomato, tomato, what's the word really mean? So the answer is no to number two, because it was not done. Patience is placed in restraints to avoid injury. Do we have any record here that the patient was placed on restraints? Nope. I don't see that. Now, is that a safety practice, control safety? It can be. There's behavioral restraints as opposed to safety restraints. When I say safety restraints, I'm thinking about a patient who's intubated that might accidentally pull his respiratory tube out, and you might want to restrain his wrist to keep him from doing that because they're not conscious, they're not with it. And so that's a safety restraint. But when you're looking at behavioral restraints, someone that may be violent, physical, remember always restraints is the last resort. But if it becomes necessary in behavior situations, the patient may require to be restrained physically. And so those are a lot of things to keep in mind protocol. But always remember that restraints should be your last resort. You can try everything else first, whether it's talking, whether it's medications, but you don't want to restrain unless you absolutely have to, but there can be. And there's a whole list of things you need to do for restraints, which we talk about later. Okay, so the answer is he was not restrained. Did security escort the patient? Well, we see here that that he does not leave Ira alone. So it looks like he escorts Ira. So that sounds like a good safety check. So that makes sense. Flagging the record for dangerousness. Yeah, they put an alert on the there, so that is a good thing for other staff members to know and be aware of what's going on. Security remains posted outside the exam room. So he is being posted and making sure that they're observing. So that one makes sense. So 1, 4, 5, and 6, if you did all those, very good. Okay, now let's go to the next question. Now, after de-escalation techniques and redirecting, the psychiatric nurse gets Ira to talk about why he believes he was brought to the hospital. Ira says, "You know what happened? Nothing new. Just the same old crap about those pills, that they are supposed to help me, but they make me sick. I don't feel alive anymore. No one can help me. I'm just hopeless." Um, I got a comments here that the ED nurse played a part in safety. Yes, because the ED nurse was the one that flagged the chart. She put on, or she or he put alert on the chart to determine that, and call the site nurse to give report. So the ED nurse did a great job in making sure that those safety protocols were being followed. So yes, she gets credit for that. Okay. Now, the question here is, complete the sentence by selecting from the drop-down menu. The nurse demonstrates understanding of therapeutic communication when she responds to the patient saying, so remember, this is what the patient said. What is her response? Did she say it could be worse? Are you becoming discouraged? Can you tell me more? Let's talk about this after the doctor evaluates you, or I know how you are feeling. So 1, 2, 3, or 4, which one do you think is the most appropriate way of communicating? All right, looks like everyone's giving me the same answer, so you guys are on the ball with this one. So yes, looking good so far. Okay. So we have a client here, Ira, who had just basically said, "I don't want to take my medication. It makes me feel sick. I don't feel good," and feels helpless, hopeless. No one can help me. This is what he says. So the nurse's therapeutic response should not be, one, it could be worse. My goodness, how defeating would that be? Do you think that's going to help Ira by telling him, well, it could be worse? So that doesn't sound therapeutic at all. I don't think anybody selected that. Thank you. Number 2, are you becoming discouraged? Can you tell me more? So are you becoming discouraged is looking at restating what the patient said in your own words. In other words, it's an observation. It's repeating what the patient said in saying, what I'm understanding is, or what you are saying is, you're feeling discouraged. That's restating. That's looking at and using good therapeutic communication to describe what you feel or you perceive what the patient is saying. So you're getting clarification. You're feeling discouraged. Let's talk some more. So that allows the client to be able to open up and share more information that may give a clue as to what's going on with the patient. Um, Let me go back to that in just a moment. Divine, because I'm not sure what you're saying about that one. But let's finish this one. So number 2 sounds like a really good response, doesn't it? At least a therapeutic one. Number 3, let's talk about this after the doctor evaluates you. The patient's already feeling discouraged, right? By saying, let's talk later, you're giving them more discouragement. You're making them feel like they're not important. And remember that we're supposed to advocate for the patient. We are speaking on their behalf. To understand what's happening with the patient, postponing it or passing the buck to somebody else makes the patient feel less important, and you're not building up that trust relationship. So that is definitely not a therapeutic response. Number 4, I know how you're feeling. Really? You got bipolar too? I don't know. I mean, people can have similar experiences, but you will never, ever know what another person's feeling. Okay? You cannot walk until you're walking in their shoes, the old saying says, right? Maybe they went through cancer and you went through cancer, but their experience is going to be different than your experiences. So it's never going to be therapeutic to say, I know how you're feeling. That's always a non-therapeutic response. Okay. So therapeutic response here would be, the correct answer would be, are you becoming discouraged? Can you tell me more? Because that's what we're trying to do here. We kind of determine. Now, I do want to go back to the previous question because somebody made a comment. Security remains posted outside the exam room. He does not leave Ira alone with the nursing staff. He escorts Ira to the psychiatric counseling office rather than releasing Ira to move to the hospital. So even though it didn't say it specifically in those words, my understanding is the security officer remains with the client. Basically, he escorted him to the psychiatric area. Now, of course, you don't expect the security office to be in the room while they're performing and asking for privacy for HIPAA, but he's right outside the room. So he didn't allow the Ira to be moving through the hospital. So he's standing guard. So I think it's inferred. So I think it makes sense that number 6 is correct. So even though it didn't say it word for word. Okay, but I'm glad you brought that up. You never know. All right, let's move on. Let's take a look at this next question. List the nursing activities that would be performed during the orientation phase of a therapeutic nurse-client relationship. Okay, so we're looking at number 1, nursing activity 1, 2, and 3. So we're going to drag the responses from the list below to the nursing activity targets above. So for example, what would be the first nursing activity that we would be doing? So we would look here as saying, do we establishing mutual goals? Would that be 1? Is it identify client resources, modifying a care plan, referring to supportive resources, reviewing final discharge instructions, monitoring vital signs, developing rapport, evaluating progress towards meeting goals? So what can help you here to organize is thinking about the nursing process. What are some of the things that you want to do first, second, and third? Eliminate those answers that really would not be part of that therapeutic client relationship. Okay? So to make it easier as a group, we're going to use this side as 1, 2, 3, 4, 5, 6, 7, 8. So tell me which one would be number 1. Pick a number. Okay, I'm seeing some of you guys giving me different answers. So let's see what the majority has to say. Okay, how we all doing? All right, we got a lot of good answers. Phase. All right, so let's start with this. Nursing number one, let's take a look at what the answer is here. The answer is establishing mutual goals. All right, so why is that important? When you think about the orientation phase, um, we're looking at the nurse represents the beginning of the partnership between the nurse and the client. And at this point, the nurse informs the client about his or her nursing role, completes a client assessment, works with the client to develop mutual agreed upon goals for the relationship, and asks the client about his or her expectations for the relationship, and inform the client about nursing expectations for the relationship. A lot of you said developing a rapport. Developing a rapport is a good answer. However, this takes time. This is not going to be the initial. Developing a rapport requires building trust. Is starting with some of these other areas of assessment, discussing mutual goals, letting the client know that you're interested in what they have to say, that they have certain control. One of the biggest challenges clients have in general, not just psychiatric patients, any patient, when they're in the hospital, is they lose control. And that is very scary for patients. That's why you get clients that can get very angry, or testy about certain things because they feel like they have no control or any decision making power. Psychiatric patients are especially sensitive to that when they feel like they're not in control or they have no say so in what you, the caregivers, are doing to them. So by establishing mutual goal, you're basically saying, look, I'm here to work with you. These are some of the things that we're going to be working on together. So that's the beginning of that trust relationship, by establishing those mutual goals. Okay, does that make sense? Okay, now number two, the second part of the activity is, what do we want to do here? This is what we call the working phase. So what, there's a working phase and resolution phase, but during this first orientation phase, the second thing is what? What are we doing now? We're looking at 2, 3, 4, 5, 6, 7, 8. What would be the right answer? And I already kind of gave you the definition. I read it off the notes, so so I think I gave you some of that answers already. Okay, since we are running out of time, I want to go ahead and give you the next answer. And a lot of you got it right. This is identifying the client resources. Okay, so again, we want to make sure that when we're looking at the assessment, we develop mutual agreements and relationships by his or her expectations. We talked about that. And the nurse works with the client to achieving mutual established goals. So the nurse will advocate for the client to ensure the client's perspectives, priorities are reflected in the plan of care. So that would be that's part of the working phase. So number three, a part of the orientation phase would be what? What are we looking at the next step after identifying resources? Because we've already established goals, we build up a trust, we identify the client resources, and now what we want to do is, or what are we working towards? You all said it earlier. The answer is, now we're developing that rapport. Because you see what we've done, we have built up to that. Now we're done with the orientation phase. Now we're going to be moving into the working phase. And after the working phase, we're going to go into the resolution phase. So part of the working phase is what I said earlier. You're achieving those mutual goals. You're working on those goals right now. You're establishing that. Uh, Looking at resources. Then the resolutions phase is ending the phase, the final stage in which the nurse-client relationship, this is based on that mutual understanding again, and celebrating that they met the goals and have been met. The nurse and the client must recognize the loss may accompany the ending of the relationship, but should share feelings related to the ending of the therapeutic relationship. So during the working phase, you might be modifying the care plan. Okay. You may be referring to reviewing well, monitor vital signs is really not having to do with that. That's more of a clinical assessment. And then evaluating progress towards meeting goals. So modifying the plan, evaluating progress would be part of that working phase. And the resolution phase is reviewing discharge instruction and referring them to supported resources outside. That would be the discharge part. Okay. All right. That was a little trickier, right? Wasn't it? Okay, now I think we have one more question. So click to identify which example is consistent with each therapeutic communication strategy below. Only select one therapeutic communicating strategy per example. So here, our example is centering on the key elements of the client's message. If we're doing this, are we using silence, restating, validating, focusing, classification, or summarizing? Okay. Now, for the sake of time, we're just going to go through this real quickly, and hopefully I can explain what they are. These two first before the other. Because Matilda, first of all, vital signs has nothing to do with the client need relationship. That's a clinical thing. That has nothing to do that. So that one's just like a not applicable. And the other ones are done, but they're done within the different phases. You want to always establish your goals. You want to establish a rapport. You want to identify the needs and resources available to complete the plan of care. That's the orientation phase. The working phase is now you've implemented it. Now you're doing it. You're using the resources, the medications, the treatment plans. This is all the stuff that you're doing to help the patient get back to that place where they're stable, whether it's modifying their medication, watching their diet, helping them establish goals. I mean, keep up with their goals, all those things that you do in the working phase. And then the resolution phase is you're working towards that discharge. You're working for identifying what they're going to need for continuity of care and so forth. Okay, does that make sense? All right, so in summary, let's take a look. Centering the key elements of the client's message has to do with focusing. When we're focusing, the key element here is when we're looking at the key elements of this client's message is we're listening to the patient and we're identifying this is what they're talking about. We're focusing on that, okay? When we're affirming that a client's response is logical and acceptable, that means they're doing what they're supposed to do, we're validating. That's what that means. We're validating the behavior. When we review with the client key aspects of your conversation with them, when we're reviewing, what would that be? I think a lot of you know what that one should be, right? It should be looking at summarizing. When we're expressing the client's message in a different way, that is what we think about when we're restating. Allow clients time to think and gain insight into their situation. Yep, you got it. And checking to see if your understanding of the clients is correct is clarifying. So these are therapeutic communications that you need to be aware of because they can be very important and they are therapeutic. They're part of the therapeutic communication. So we want to make sure that when we're looking at therapeutic that we're using things like restating, validating, clarifying, summarizing, use of silence. What we don't want, which would be non-therapeutic, is thinking about the why. Don't worry, close-ended questions, or looking at authoritative answers. Authoritative answers is, this is what I think you should do. You should take your medication the way the doctor said. That's being authoritative. I'm the nurse. I'm telling you what to do. Okay. When you take the center off the client, when the client is no longer the center and you're saying, I know I went through the same thing with my mother last year. So you're expressing your ideas, your feelings, your thoughts, and the client is not no longer in the center. So those are non-therapeutic responses. So you don't want to use those. You want to eliminate those type of answers. Those would be non-therapeutic. Okay. All right. And that's the end of our webinar. I know we went over a few minutes here. Sorry about that. So what do you think? You guys feel a little bit better with psychosocial questions? Okay. So a lot of these are behavioral questions when you're thinking about things like what would be the best response for the nurse. Don't forget to use those therapeutic communication techniques and skills to help you eliminate, first of all, the wrong answers. Most of the time, you end up with the right answers. Okay. All right. Well, I do thank you for this time. I appreciate you hanging out with me. Hopefully that we've learned something today. Don't forget, you got one more opportunity to come tomorrow to do this again if you need to repeat it at any time. Until next week, this is Susie Caldero saying bye-bye, everybody. Thank you.